Okay, so what do you want to talk about?
Let's talk about strokes.
Yay, my favorite subject.
Okay, well, I'll ask the questions today then, Dr. Modi. We'll pick your brain on strokes.
All right, Kelly, let's talk about it.
Okay, awesome. So let's talk a little bit more about the scope of the problem. Tell me about that.
So in United States, like 800,000 strokes occur per year.
Wow.
That's almost close to how many heart attacks occurs per year in the United States. People are way more familiar with heart attack. You know, you go out there and ask even kids, they would know what heart attack is, but there's not that much awareness and knowledge about stroke. And with aging population, this incidence of stroke is just going to go up over time.
Absolutely. And we do have a very large aging population in the United States right now. So it's definitely a good thing for lay people to be able to recognize the signs and symptoms of stroke.
Yes, absolutely.
So what are some things that people should be looking out for in terms of signs and symptoms?
So there is an acronym to recognize a stroke early on, and that is be fast.
Okay.
And the phrase itself suggests that you got to be fast. The be fast stands for, B is for balance. So there is any sudden problem with balance, loss of balance, dizziness. E means eye, and loss of vision, sudden loss of vision in one eye or both eyes. F stands for face. That means facial droop, like one side of the face is droopier than the other side. A is for arm. One side of the arm is weaker than the other side. And easier way to test it is just ask the person to extend their arms in the front, and then the weak arm will drift down slowly. And S stands for speech. Speech problems like slurred speech, difficulty with comprehension, and difficulty with expressions. Means the words don't come out right, or they can't understand what others are saying.
Wow.
And last one is the T for time, means it's time to act, call 911. And this is what Be Fast stands for. I think everyone should know about this.
It sounds like a great and easy to remember acronym to help the public recognize this, because like you said, time is brain. So what can we do to get to 911, to get to help, to get to medical care as quickly as possible?
Yeah. In acute stroke, 2 million neurons die every minute.
Oh, wow.
So you can imagine even 1 hour delay can cause a lot of damage in the brain. Now, of course, this is like on an average. You know,
Sure.
Some strokes are so much smaller and some are so much bigger. So there's a wide variation of how fast the brain can die. But 2 million per minute.
That is a lot. And, you know, that kind of reminds me, I guess we should go back to talk about what exactly is a stroke? Like, what is happening in our brain when we have a stroke, and are there different types?
Yes, absolutely. So stroke are two kinds. There's one kind called ischemic stroke, and the other one is hemorrhagic stroke. The ischemic strokes are a vast bulk of stroke, with 85% of the strokes are ischemic stroke, and about 15% are hemorrhagic stroke. So when we use the word stroke in general, it implies that it's an ischemic stroke.
Okay.
And ischemia means lack of blood flow to a tissue. And so in an ischemic stroke, there's a blockage of some blood vessel in the brain, and the tissue supplied by that blood vessel starts dying because of lack of nutrients. The tissue starts dying within a few minutes, actually, but it may take hours before the tissue completely dies. So you got to act within those first few hours and see if you can restore the blood flow so you can prevent more damage from happening. And then there's the other kind of stroke, hemorrhagic stroke. About 15% of strokes are like that. And that does not involve blockage, but it involves bursting of a blood vessel.
So it sounds like it definitely, maybe there's a chance, if we catch it soon enough, that if we reperfuse an area or we prevent the bleeding from getting too profuse, that we could get some of those brain cells back. We could get some brain power back.
Yes.
Is that right?
Yes, that's a principle of hyperacute stroke treatment. In the first few hours, the stroke treatment needs very aggressive and fast interventions to restore that blood flow. So the first thing, if you recognize stroke symptoms in yourself or in another person, call 911. Don't bring them to hospital by yourself. Just call 911. There are so many things that medics can do that you can't.
What can they do? What can they do for a stroke on an ambulance?
Like, for example, when they come in on site, they can see if there is anything else that can cause stroke-like symptoms. I mean, simple things like low sugar can cause stroke-like symptoms. So you just give orange juice and you're better. So then you don't need to come to the hospital. So things like that. And then medics can notify the hospital before they come into the hospital, so the emergency room is ready to receive the patient. Another important thing is sometimes, depending on the severity of the stroke, patient may need to go to a tertiary care hospital if it's a severe stroke, and bypass smaller hospitals, because if it's a severe stroke and you go to a small freestanding emergency room,
you're just killing time. You're not at the right place. Yeah,
absolutely. They're going to transfer you to a tertiary care hospital anyway. So medics can triage. Sometimes some of the medic units have a CT scan, and
that's amazing.
Yeah, absolutely. Yeah, they are the mobile stroke units. There are some cities and some healthcare systems that has this, and basically, patient gets a CT scan in the medic unit, and there's usually a neurologist on the telemedicine call, and they can start treatment early on.
That's incredible. I used to work for Cary EMS. So I was an EMT on these 911 ambulances. And that would have been something I would have loved to have. And what your story about maybe high blood sugar can mask as a stroke reminds me of this call that I got. It was like 2 a.m. on a very rainy night. And someone had come across a guy that was in a ditch, and it was pouring rain on him. So we got this 911 call, and we show up, and there's a guy covered in mud in the ditch, and it looks like he had a stroke, and it very much appears like he had a stroke. But lying on his porch when we went up to go into his house to kind of investigate, see if we could find any clues to what was going on, were a bunch of blood glucose strips. So we thought he may have been a diabetic, and so we pricked his finger, and sure enough, his sugar was like 40. It was extremely low, so we were able to treat him a little bit differently. But that just reminded me of that story. I would have loved to have had a CT scanner in the mobile unit back in the day. It would have been so much easier to call that code stroke, take him to the right place, and get him treated much faster.
And not just stroke, the CT scanner in a medic unit can also help with other conditions like, polytrauma, abdominal pain emergencies, and other things.
Yeah, absolutely. That's really interesting. So then once you get to the hospital, again, preferably a stroke center, what are they going to do?
So the hospital would probably know that you're coming. They'll make sure that you're breathing okay, and your blood pressure and vitals are okay.
Sure, they'll stabilize you and get you to the CT scanner is the name of the game. If you haven't already had one of these fancy CTs in the mobile unit, right?
And now you're in the CT scan. The purpose of CT scan is actually not to diagnose a stroke, because these ischemic strokes usually cannot be seen on the CT scan in the first few hours at least. The purpose of the CT scan is actually to rule out a hemorrhage or a hemorrhagic stroke. So the treatment, you can imagine, for ischemic stroke and a hemorrhagic stroke would be very different.
Yes, absolutely. So you're looking on that CT for a bleed. So that 15% of the time that it's going to be a hemorrhagic stroke, you want to rule that out before you go down the path of treatment. And you want to probably rule out other diagnoses, like we were talking about, things that mask as stroke. So do you want to tell me a little bit more about other things that could potentially be on the differential diagnosis for someone who looks like they may have had a stroke?
Yeah, we just talked about low blood glucose.
Yes.
Even high blood glucose can also cause stroke symptoms. Other things like low oxygen levels, sometimes some toxin can cause neurological symptoms. Kidney problems, liver problems can cause neurological symptoms. Infections, sepsis, and seizures can sometimes mimic stroke. So there are so many things that can mimic, and that's why you need that more accurate clinical diagnosis at bedside.
Sure.
These days, if the hospital doesn't have a neurologist, sometimes they get a teleneurologist, especially the hospitals in these rural areas.
Oh, yeah.
There's a neurologist on the screen and camera and will help make a diagnosis.
Wow. That seems really high tech. And what a great way to reach these more rural towns and make sure that they're getting timely stroke care as well.
Yeah.
Yeah. So do you want to go into the treatments now?
In an ischemic stroke, there's a blood clot. There's a blockage in the blood vessel. So the principle is you want to open that vessel as soon as possible.
Sure.
And There are some treatments available. There are some clot-busting medications like
TPA, is that it? Yeah.
yeah, TPA. It's like a 1 hour infusion, and it tends to dissolve a blood clot which is fresh.
Oh, so it needs to be given very quickly. What's the time frame there?
So the TPA is usually given within 4.5 hours
Okay.
of onset of symptoms. After 4.5 hours, it's usually not effective. So here you can see the importance of time.
Yes, absolutely.
And there are new medications available now. There's another drug called tenecteplase, TNK, which is more preferred over TPA now because it can be easily given as just like a bolus injection.
Oh, okay. So you don't have to sit there for an hour or whatever it takes to infuse the TPA. You can just give it really quickly.
Right, yeah.
And that seems like it could be important.
Yeah.
Yeah. What else can you do for ischemic stroke? Is that really it?
If the ischemic stroke is large, if there's a large blood clot, like for example, a clot that's clogging a carotid artery
Sure.
or a large artery in the brain, then TPA or TNK will probably not work because the clot burden is so big. Those clots need to be removed mechanically. These procedures have to be done very fast, you can imagine.
Yeah. So let's talk about the process from getting the patient from that CT scanner where you think you know what's going on with them to their treatment, whether it be a thrombectomy, TPA, or any of these new medications that bust the clot. How long does that usually take? What kind of things are involved in getting the system involved to make that the quickest possible time? And do you have a personal best?
Yeah, absolutely.
Tell me about that.
Yeah, so you can imagine it takes a lot of people in the first few minutes and hours to manage stroke in a hyperacute state. It takes an emergency room doctor, nurse, PA or nurse practitioner, neurologist, radiologist, CT scan tech, pharmacist.
Oh my gosh.
And you can imagine the whole process being so complicated. So all these hospitals, they try to track and improve this process. So we track like a door to needle time, means how much time it takes from patients hitting the emergency room door to actually getting TPA or TNK. We also track door to CT time. We track door to revascularization time, means how much time it takes for patient from coming to the hospital and all the way to the revascularization, means the blood vessel opening up with a clot removal procedure.
Sure. So how long does all that typically take?
So we have been improving a lot. So I have been doing this since the last 10 years.
Wow.
And I have seen significant improvement. So like 10 years ago, I can imagine, I remember things were a little bit slower. And for example, door to needle time was about 1 hour. And nowadays, a lot of hospitals are achieving that in less than 30 minutes.
Wow, that's spectacular. I bet that saves a lot of lives.
Yeah, it makes a difference in the outcome. Sooner you give the drug, the better.
Absolutely.
And although surprisingly, not a lot of patients get TPA.
Really? So what's happening instead? Is it the TNK?
Or TNK, yes. Either drug. The problem is patients are often not coming in on time, or it's a wake-up stroke, means they wake up in the morning with stroke symptoms. So we wouldn't know when the stroke actually started.
So it's too late for these medications. It's not that they're not working or the time is wrong in terms of like a hospital process. It's that the people are not getting to hospital on time. They're not getting
Yes, exactly. Yeah. Nowadays, though, there are some more imaging techniques to figure out if there is actually tissue at risk and if patients will benefit from TPA or not, regardless of what was the time of onset or what was the time of last known normal.
Sure.
But still, like 10%, 12% patients get TPA. That's not a big number.
No, it's not. Yeah, that would be surprising to me, but it totally makes sense that it's from the front end, people identifying and getting treatment immediately, which certainly would be hard to do if you're beginning to have a stroke when you're asleep.
Yes, exactly.
Yes.
And we track all these times. My personal best is 17 minutes.
17 minutes?
Yes.
Wow.
I got a little brain sticker from the hospital.
Oh.
It's like,
I feel like that's classic. I worked somewhere for 5 years and I got a gold star pin for my white coat.
oh, wow.
I'm like, I was here through COVID. Nights, call, and weekends. No, I totally understand. That's so funny. Anything else you want to tell us about the treatment for ischemic stroke?
Now the patients are going to be admitted to the hospital, and then there will be investigations going on. Like now you figure out why the stroke happened, where the clot came from, and what's the chance of it happening again, so you can prevent one in the future. So you need an MRI. MRI will show like very detailed pictures. An important question that a neurologist would be trying to investigate the cause of the stroke. Now, when we're talking about ischemic stroke, there are three main causes.
Okay, what are those?
The first one is small vessel disease. The second one is large vessel disease. And the third one is cardioembolic. Yeah, so the small vessel disease involves abnormalities in the tiny little arteries in the brain, which are, thousands of them.
Sure.
And over time, with risk factors like high blood pressure, diabetes, smoking, obesity, and all those things, they can make this blood vessel age faster. And sometimes one of the vessels can just close off and the tissue supplied by that tiny vessel dies.
So it all comes down to kind of microvascular injuries that some of these chronic conditions can, and things like smoking can happen to your vessels. Yeah.
And then comes the large vessel disease, well, like large arteries, carotid arteries, or large arteries in the brain. These are like large vessels, and high blood pressure and smoking especially, that can make this large blood vessel with plaque. Over time, they get narrow, and then sometimes they can just close off. And those strokes are usually large and they're more severe.
And this is atherosclerosis that you're talking about. Yeah, absolutely. Yeah.
Exactly. The third cause of stroke is cardioembolic, means a blood clot that can form in the heart and then come into the circulation and get trapped in a vessel in the brain.
Now, is this from something like atrial fibrillation, maybe?
Yeah, good point. That's the most common cause of cardioembolic stroke.
Okay.
And since we're talking about AFib, 5% of US population has AFib, known or unknown diagnosis.
Oh man. So it definitely is something that we want to pinpoint, and these stroke victims could really be the cause based on this cardioembolic.
Yes. One of the things that if neurologists suspect that it's a cardioembolic stroke, then this is one of the things that they would be investigating, if does patient have atrial fibrillation or not.
That makes sense. Oh, wow. That's all super detailed and great information. Thank you for that.
Yeah, you know what? About 20% of the time, we can't even figure out why the stroke happened.
Wow, 20% of the time. That seems pretty large.
Yeah, absolutely.
Man, so it can be really hard to pinpoint how to prevent it. I bet that feels hard for the patient. Like, what do I do going forward if I'm doing all the right things? I got this stroke and we can't figure out why. That must be tough.
Yeah, sometimes patients are in limbo. They don't know what caused the stroke, and they don't even know what the risk of it happening again. Sometimes it happens again. And you still don't know the cause.
Absolutely.
And we can talk about hemorrhagic stroke since we touch base this topic.
Yeah, let's do it.
The hemorrhagic stroke involves the rupture of a blood vessel and blood leaking out. The bursting of blood vessel can cause this big hematoma in the brain. The collection of blood, it can be small, it can be large, and depending on the location and size, it determines its severity.
So what is the danger with the hemorrhagic stroke? Is it that blood is pooling around the brain? Is it the loss of nutrients to certain areas of the brain, the blood loss itself? Tell me a little bit about the pathophysiology of that.
When there's a bleeding in the brain, pressure effect on the surrounding tissue. So just by that pressure, some of the tissue dies, and then blood is in a way toxic if it's outside the blood vessel.
Sure, it's like an irritant, right, to the rest of the brain.
Exactly. So the surrounding area swells, there is immune reaction, and so on. So that's how it damages the brain.
So mass effect plus plus inflammation, basically. Yes. Okay, that makes sense. And what can we do for that?
In order to prevent the stroke, the same risk factor applies as an ischemic stroke. Aging of blood vessels caused by high blood pressure, smoking, diabetes, high cholesterol, obesity, sleep apnea. High blood pressure would be at the top of the list. Yes. And so when a patient comes with an hemorrhagic stroke in the hospital, the first priority is to control the blood pressure.
Isn't that why they call hypertension the silent killer? Is it because of stroke, hemorrhagic stroke? Do I remember that correctly?
Yes, and so many other things that comes with hypertension.
Absolutely, yeah. Oh man, okay. So what can we do? Do they have to go in surgically and stop the bleeding, clip it? Like what kinds of interventions are there for a hemorrhagic stroke?
So for the hemorrhagic stroke, usually the best intervention is to control the blood pressure and prevent more bleeding from occurring in the brain. And if a patient is on blood thinners, then give medication that can reverse the effect of blood thinners. Usually the treatment is conservative. Usually surgeries are not done unless the bleeding is large enough to cause severe mass effect in the brain. Patient is in coma and things like that. So in that case, the surgeon has to remove a bone flap in order for brain to expand and sometimes even remove hematoma.
Wow. Okay. That sounds pretty intense, but generally trying to manage that conservatively just by bringing the blood pressure down, hoping that the oozing of blood kind of stops and essentially the vessel kind of coagulates on its own. Is that what that exactly. Is? Yeah. Yes. Okay. Do people ever go in with a coil, like with interventional radiology, to embolize that area? Is that something that's being done? I'm hearing a lot about more IR procedures where things are being embolized lately, like prostatic artery embolization, et cetera. Tell me about the role of that in stroke. Do you know?
Yeah, that would be uncommon. There are some vascular disorders, some vascular malformations in the brain, and sometimes aneurysm in the brain that can burst and cause bleeding. In those situations, you may either need surgery or you need to go with a catheter and embolize the blood vessel or pack the aneurysm so it doesn't bleed again.
Okay, gotcha. That makes sense. I feel like we just had a good conversation about strokes. I'm learning a lot. So let's talk about what happens after the stroke. Can you talk to me about some of the deficits that stroke victims may be left with and what kind of options there are for them to regain some sense of normalcy?
Yeah, good question. So the stroke, you can imagine, can be very mild or severe. And what matters more is the location of the stroke. So you can have a small area of stroke in a very strategic location in the brain and can cause severe symptoms.
Sure.
And you can have a little bit bigger stroke and have no symptoms at all. So it's not just the size, it's more of a location that matters. And depending on the severity, there are different rehab options. Younger patients recover better, so they get more aggressive rehab. Usually they can tolerate more aggressive rehab.
Sure.
And older individual needs more slower, longer term rehab.
That makes sense. I guess younger people have more cognitive reserve. Is that a term that I'm using correctly?
Yes, the remainder of the brain, which is not damaged, it has a capacity to take over the function that is lost. So that can happen more dynamically in younger individuals.
Sure. It's like new neural networks building around the damaged one, sort of circumventing that, creating a new way of doing something that you were doing before. Is that right?
Yes, exactly.
Okay. That's super interesting. I love that. So Dr. Moody, you used to work in the neuro ICU and you saw a lot of strokes. Can you tell me about sort of your days doing that as a stroke neurologist?
Our days can be quite unpredictable because we deal mostly with some of these emergencies that come into the hospital. Some of the days are extremely busy and some of the days we don't have much to do. And it's usually running around in the hospital, responding to your pager. Pager is going to be there with you all the time.
Yes.
And it can be multiple times in a minute.
Yeah, just depending on how many strokes are coming in, and it's totally hit or miss, right?
Yes, absolutely. And then we assess the patient in the emergency room. We admit them to the hospital, to a neurology floor or neuro ICU. We see them every day when we round. We try to investigate why they are having stroke. We talk with patient and family, educate them over their diagnosis and the cause and prevention. And then we determine where the patient goes next, for whether the patient goes home or rehab.
Sure. That makes sense. And it sounds like you'd be involved in a lot of care coordination too, bringing in speech therapists, physical therapists, occupational therapists, all kinds of things to kind of care for that patient holistically together to get them back to their daily life in whatever capacity is then appropriate for them.
Yeah, you're right. Yeah. Absolutely.
That makes sense. Well, thank you so much for talking to us today about strokes. This has been enlightening, I'm sure, for our audience, but for me as well. So thanks for your knowledge today. Thanks, everybody, for listening, and we'll see you next time on the Neurology Nook.